Thank you, Elizabeth, for the introduction. And it's great to see so many people on the call. Many of you I have worked with over the years, and there's many new faces there too. And as I go through my material today, there's many of you on the call who've made a contribution to this work. So I'll hopefully give you a shout out as we go through the slide deck. So I'm going to put us on screen share and take us through a slide deck, which will be my presentation. And I've also sent to Jaris and to Elizabeth some material that can go on the Teams channel, so some papers and other information, which I will kind of mention as I go through the talk. So let me just pop us onto screen share, see if this is going to come up. Okay, so hopefully you can see my screen.
That's absolutely grand, we can indeed.
Okay, so I'm going to talk to you about seeing healthcare from above. So I'm going to do a little introduction to myself, and then I'm going to tell you, take you on a journey through some of the work that I've been involved with. But as we go through that, I want to share with you some particular insights that have been kind of gathered along the way as I've kind of gone through this work and worked in partnership and collaboration with so many people. So my name is Tom Innes. I work through my consultancy, Cofink, but I also work at Strathclyde. I'm in Strathclyde today as a research fellow on a number of research projects, and I'm a visiting professor at Heriot-Watt University as well. In all the work I do, I would describe myself as a design and systems facilitator and educator. Not all of my work is in health and care, but a lot of it is. And I've put here working with health and care professionals. I seem to spend a lot of time hanging out with health and care professionals. I find the whole world of health and care absolutely fascinating, and a place where that there's all sorts of insights that can be kind of gathered and gleaned by taking a design approach and increasingly a systems approach. And so it's a delight to be with all of you today, because you are a community of practice who I think celebrate those approaches as well. So hopefully I have a friendly audience today as I go through my material. Okay, so in my work, I do a lot of work with health and care startups. So I work with Innovate UK, with startups across the UK. These are largely run by health and care professionals. A lot of them have been set up by clinicians who are trying to kind of innovate from most of them have actually become frustrated from innovating on the inside and have stepped outside health and care. Many of them still have professional roles, but are setting up companies, a lot of them in the digital space, and got some extremely innovative solutions to health and care problems, but then have the challenge of kind of selling them back into the system. So a lot of my work is in that space. I do work with health and care QI teams, and in particular, introduce them into design methods. And I think that's an area you're familiar with. So a lot of that work has been through NHS Tayside, some of the other Scottish boards, and a lot of work in Northern Ireland as well. The thing I'm going to talk about today is patient ecosystem mapping. So it's kind of it's kind of like a kind of a methodology or a way of actually seeing potential improvements and innovations in healthcare through more of a systems lens. And alongside this, with my kind of academic roles, I'm involved with a series of research projects. So one moment is seismic shift, which is with NHS Highlands and Lanarkshire. That's with Strathclyde, and a big project called Design Hopes, which is running with NHS Scotland and a number of universities in Scotland. Okay, so I'm going to talk mainly about patient ecosystem mapping, but I'll give us a kind of gentle intro through design methods for healthcare, and I'll also tie it into some of the research projects that are going on at the moment as well. So just as a bit of background, my work in this space began probably 5 years ago now, working very much with the team at Tayside. So it's great to see Hilary on the call and Rod Mountain as well. So a lot of this work was done very, very closely with Rod, who'd been a pioneer in bringing design thinking, obviously, into the work of NHS Tayside. I worked with Rod and the QI team there to actually kind of create a more formalized design curriculum for their Tayside Quality Improvement Programme, which now has design methodology running completely alongside QI methodology in the way the kind of programme operates. So Tayside's been a very early adopter, as you know, in a lot of design methodology. So that was the kind of start of my design journey in healthcare. Rod and I wrote a paper about it, which is available to you. We've put it on the Teams channel. It's called Designing Realistic Healthcare Improvements. This was written in 2020. it describes that work with TQIP in Tayside through the lens of realistic medicine. And it's kind of interesting. I think realistic medicine, it kind of went into the background a little bit during the pandemic, but I can see that many of the concepts within realistic medicine are really coming to the fore now. And design methodology, as you probably appreciate, is an excellent way of actually thinking about implementing some of those kind of realistic medicine approaches in healthcare innovation. Okay, so now I kind of do a lot of that design methods training. So I run one-day courses and longer programs with various boards and so on, bringing those design methods in. So I always think of everybody who's a health and care professional being a silent designer. You all design things all the time. You've not necessarily had a formal design education, but there are all sorts of design thinking approaches that you can take on board, which will really fine-tune your design abilities in your day-to-day job. So that's what these kind of programs are very much about. Okay, well, let's just kind of flip on from design and just kind of move into the world of systems for a moment, because this is very much where my kind of design thinking has taken me, particularly over the last 3 years, really. And I find the whole world of systems thinking really, really interesting, because healthcare is just a massive, great big system. And design approaches have great value, but in a sense, they do have limitations as well. And I think this diagram really does summarize one of the limitations that we have if we don't take a systemic approach to innovation. I've got 4 levels here of innovation. This could be in any system. This is kind of described through the lens of healthcare. And I've got level 1, level 2, level 3, and level 4. And I, having kind of worked with many colleagues and collaborators in healthcare, I'm pretty much of the opinion that about 95% of all quality improvement in healthcare happens at level 1. It's where you've got an incredibly well-meaning project, which has probably been quite clearly defined, but it's a redesign project of something, an improvement project of something with a poor system understanding. So it understands the very, very specific problem in front of the QI team, but it doesn't really understand what's to the left and the right of it and what the kind of repercussions of that improvement might be. So 95% of improvement is at level 1. Level 2 is where we make an improvement, we have a system awareness, so we know what's going on to the left and the right of us. So we might be making an improvement in secondary care, but we know what primary care interfaces we're dealing with and what care at home interfaces we're dealing with. So that's a kind of an improvement. Level 3, though, is probably where healthcare needs to be, and that's system shifting. You're not really going to get the transformation healthcare needs without taking a system shifting approach. And that means you need a prioritized portfolio of improvement activity across a system. You have to understand what the system actually looks like, how it performs, how it works. And then you very strategically, you have to kind of then make a series of interventions, which are kind of scheduled and programmed in order to kind of shift the system on. And probably in an ideal world, you'd be on level 4. That's where you can kind of model you've got the as is system, and you can model what the to be system is. And you could, if you know, in a dream scenario, you'd be able to close the entire NHS system down on a Sunday night at midnight, open it again at 1 minute past midnight on a Monday morning, and it would be a completely transformed system. Unfortunately, you can't do that. It's like kind of redesigning an aeroplane whilst it's still flying. It's kind of technically impossible, but actually kind of taking the time to actually visualize and imagine what an idealized system could be like, that high level speculation and modeling of system redesign can be incredibly powerful. So really, we should try and be at level 3. That's where we get the most impact. And really, you know, NHS systems are kind of crying out for a level 3 intervention. So how do we actually do that? Well, interestingly, going back to Tayside, going back to the pandemic, I was involved in a very, very interesting project. It was done with Rod Mountain, who's on the call now, Shobhan Thakur at NHS Tayside, Laura Allison at NES. We did this little kind of review of how the system was kind of innovating incredibly interestingly during COVID. And we kind of found lots of things out which were kind of very logical. During COVID, teams were empowered, everyone could work across silos. There was a shared aim called dealing with a pandemic, and there was lots of innovation across the system. But through that little piece of work, it became quite clear that there was a kind of limit to the number of tools and methodologies that are available to support that kind of systemic review of what was going on. So we had the opportunity to apply for some research funding through UKRI, and we ran a little project through the University of Strathclyde with NES and NHS Tayside, looking at could you actually create a methodology for kind of mapping a healthcare system in a kind of slightly more innovative way. Now, I've always been incredibly interested in a geeky way in transport maps. So one of my favorite transport maps is the London Underground map. And here's my my dream slide showing you the London Underground map. Top left-hand corner, that's what the Underground really looks like. It looks like a plate of spaghetti. That's a geographically correct map. Harry Beck here in the middle in the 1930s, he was a designer. He came up with a kind of methodology for mapping out tube lines and created the London Underground map as we know it today, which is this kind of connection of lines through stations and so on. It's not geographically correct, it's stylized, but it's incredibly clear. And if you're a traveller around London, you can very quickly find your way from point A to point B. And over time, it's become part of a much bigger Transport for London map, and it's got zones in it and so on. And it shows bus interfaces and railway interfaces. So it's kind of, it's been allowed to grow. And these kind of maps, I think, are incredibly interesting. It's static, it's not dynamic. It doesn't show you what's going on day to day, but it shows you the intersections between lines. And I think there's a huge amount of similarity between that pile of spaghetti, the London Underground system map, and actually what a healthcare system looks like. You have here the Victoria line. That's like the cardiology line, which intersects with the diabetes line, which intersects with the cardiovascular line. Patients come in on the cardiology line. They have to step off at a certain point, go onto another line. They might be on the circle line for a period of time. They start off in zone 5, which is where they live. They have to go into the centre for their treatment into zone 1, and then they have to go back out to zone 5 again. They have to get to their station by using a bus or using an Uber. So it's kind of, there are kind of enormous kind of similarities between the two. So we set ourselves the task within our UKR grant. Could we kind of come up with a methodology? And if you could kind of map these things, what would you do with the maps anyway? So it's kind of quite a speculative project. We ran all sorts of different mapping exercises with different groups. So we're working with Rod, who's on the call, who's an ENT surgeon. We looked at ENT with Shobhan. We looked at emergency medicine at Tayside. And each one was a kind of, we had to kind of go at mapping the system and trying to kind of come up with a representation. It became very clear that it was possible to do it, but you had to kind of come up with a kind of clear set of rules to make this repeatable, if you like. So we've got a very, very simplistic set of rules for kind of creating these maps. This is the kind of legend, sits in the corner of the map. So all of the maps are made up of representations of a patient journey. All patients or service users go through a journey which involves probably 5 or 6 steps. Step 1 is always the trigger for the pathway, signposting to the pathway, diagnosis, assessment, treatment, exit, discharge. You might do that in 5 minutes. You might do that in 5 days. You might do that in 5 weeks. You might be going round and round in circles over 15 years. It really depends on what conditions prevail for you. And there's always step 0, which is preventing the need for the pathway in the first place. So that's kind of rather like the zones of our London Underground. When you are a patient, you know, according to the kind of rules of service design, you interact with people. So you always interact with certain people. And in healthcare, you tend to interact with lots and lots of people as you go through that journey. And the interactions take place in different settings. The settings are kind of organized in different ways. And you, the patient, are the person who makes the connections. So based on that methodology, we've got a very, very high level, it's kind of what I call a baseline map. This is kind of totally generic, but this is probably representative of most generic healthcare systems. It says generic NHS. I've kind of used this model in Norway now and in Canada, and it actually kind of maps quite well onto a Canadian healthcare system or a Norwegian one as well. The vocabulary is very different and the emphasis is very different. Some of them have NHS 24 equivalents, some of them don't. But we have here the kind of baseline map. We've got people starting at home. That's where you can have 0, preventing the need. There's all of these little blue circles are all of the ways that you can kind of enter the healthcare system. And you might get onto circle number 2, which is where you get signposted somewhere else if your health needs are scaling and going up. And the red circles represent places where you can get treatment, or diagnosis. Diagnosis is number 3. Treatment is number 4, the red circles. And it's a little bit like a board game. You start on the 0 circle, and depending on what your condition is, you have to kind of work your way around the system. So we could sell this as a board game for Christmas. If it was urgent care, the aim of the game would be to go from the grey circle to a red dot within 24 hours. And you roll the dice and you make your way around the system and you kind of circulate around it. But it is kind of, it does have system characteristics, because it kind of, you flow in and you flow out. And interestingly, each one of these different kind of colour boxes is kind of organised in a different way. Secondary care is organised in a different way to primary care, which is organised in a different way to community services. So there's kind of different governance structures and so on, and drivers within each system. Okay, so that's kind of very useful. You can create a pretty map. But actually, the interesting thing about the map is that it's kind of what role does that map play in improvement, which is the really, really interesting question. So over a kind of process of iteration, I've got this kind of now wrestled down into kind of 3 steps really, which allow this kind of systemic view to be had using this kind of approach. So step 1 is you have to co-create an ecosystem map. So you can start with the baseline map, but then you've got to define the scope of what is it you want to actually map. And I've got some little examples here. I've done this with social prescribing in Angus. This is urgent care in Belfast. And down at the bottom, I've got clinical genetics in Scotland. We'll say a little bit more about those examples in a moment. So you define the scope of the map with your team, and then you co-create the map. In order to create these maps, one person can't create the map. You've got to get input from representatives from across the system. And this is the first piece of enormous value add, because generally nobody has oversight of what the system actually looks like. So some people might know what the hospital system looks like in great detail, but they won't know what the primary care system looks like, and vice versa. So you can have an incredibly useful in conversations, actually bringing people together to create this boundary object. It's like a boundary object, this ecosystem map. And you can do that face-to-face. I've run face-to-face workshops. An awful lot of it you can do online. So using Miro, which you're very familiar with, you can run very time-efficient sessions. In Belfast, I mapped out urgent care over 10 sessions. We had over 100 participants, I think, in those sessions, 10 1.5-hour sessions. We managed to kind of create the map. So that's you go from the baseline map. This is once you've kind of co-created it, it becomes really, really complicated. So this is urgent unscheduled care in the South Eastern Trust, just outside Belfast. And I'll say a little bit more about this in a moment. Okay, so you create the map. Once you've created the map, you can then use it as a way of exploring challenges and needs. So in principle, there's 2 ways of doing that. One is invite service users to talk through their own journey. So healthcare, I think, is incredibly poor at getting patient insights into the system. So it's very good at kind of understanding challenges from a healthcare professional perspective, but it's the patient who has to actually join the system together. So the patient is the one who makes this journey. The patients do get asked about their experience in a particular box, but they never get asked about the entirety of their journey. So all of us, everyone on this call, will have had at least half a dozen experiences using healthcare as a service user, either their elderly relatives, your family, your friends, and you will know how the system kind of trips over as you kind of make these journeys and something is not done properly. But that challenge is never actually really captured by the system, because feedback systems into the system are incredibly poor, I would argue. At the worst possible case, I've worked with one healthcare board who've asked them what their feedback mechanism was, and they say, well, Tom, we've got a complaints process. Well, a complaints process is not a kind of service user feedback mechanism. So you have to kind of walk through, you can't walk through every single patient service user journey because there's literally millions of them, but you walk through representative journeys and you can begin to understand what some of the challenges are that patients are experiencing. I have My mother-in-law is 82. She's been in hospital for the last 3.5 months. She was discharged on Friday before a bank holiday weekend with a carrier bag full of drugs, 24 different drugs, and they weren't blister packed. And yesterday the GP came round and discovered that she'd actually been given completely the wrong set of drugs by the hospital. Now that's not kind of recorded. It's something that's in between the interface between primary care, secondary care and primary care. It is a challenge to the system because it's burning up a huge amount of the GP's time. There's a kind of clinical challenge in the whole thing, but it's not something you can only pick that up by mapping that service user journey through the system. So the maps provide this incredibly powerful way of taking different personas or different segments through the journey and getting them to kind of record their journeys. So we've done this with quite a lot of these service user maps, what worked well, what was challenging. And I would argue that is a form of feedback which is very rarely recorded in a systematic way at the moment in healthcare systems. It also allows you to kind of use an iceberg model. So iceberg models is a way of looking at a system. An iceberg, you might be familiar with this, iceberg, 10% of it is above the surface and 90% of it is below the surface. So above the surface, we have the events and happenings, the things you see day to day. That's what we tend to respond to. Below the surface, we have patterns and trends, which we kind of don't pick up on day to day, but are incredibly significant. Systems and structures, mental models and mindsets. So we can peer into our system model and say, what are the observable day-to-day challenges? And again, in healthcare, I think interestingly, healthcare is incredibly good at spotting day-to-day challenges, but only inside the boxes. So it's very good at not very good at seeing challenges between the boxes. So that's where the system map is incredibly useful in terms of identifying needs. Interestingly, yesterday, Healthcare Improvement Scotland decided it was going to do audits of every maternity unit in Scotland. And so that's kind of fascinating to me. That's kind of looking for observable day-to-day challenges inside a box. Yeah, all the challenges in maternity units are probably due to the fact that 1 in 10, I think it's 1 in 10 expected mothers now have diabetes. There's a 25% obesity rate, and the number of people, the age at which people are kind of presenting for into maternity units has gone up. So actually what's going on in maternity units is a complete systems issue, yet the audit and all of the analysis is around day-to-day challenges inside one box, which is called the maternity unit. So it's not a kind of systemic approach to improvement. So that's kind of an interesting one for Healthcare Improvement Scotland to note, I would argue. Okay, the next one is trends. Trends are really interesting. So the whole healthcare system is a slowly boiling frog in terms of that kind of metaphor. I'm talking to healthcare, the Scottish Unscheduled Board tomorrow, who are kind of really concerned about the number of hospital beds being consumed by unscheduled care is kind of going through the roof. That's essentially because you have an aging population, the number of people with multiple long-term conditions is going up, and healthcare inequalities are increasing. There's absolutely mind-blowing data that shows what's going to happen over the next 5 years for all of those things. Yet most system improvements are not factoring in that kind of 5-year shift at the moment and what those impacts are going to have. So understanding patterns and trends is hugely significant in the system. Systems and structures, the way primary and secondary care work, huge issue. So primary care doesn't really understand how secondary care works. Secondary care doesn't understand how primary care works. Digital systems are incompatible and so on. And very significantly, mental models and mindsets. So that's about mental models. And that's where the realistic medicine agenda really is very, very important now in terms of what the mental models of practitioners and what are the mental models of patients and service users. Patients and service users have a learned helplessness, if we're kind of really brutal about it. And healthcare professionals, interestingly, there's some really interesting challenges with their mental models too, probably as well. Okay, so that's step 2, is identifying those challenges. Step 3 is then taking it forward. So you have to plan and deliver your system shift. So if we kind of go into design methodology has a very useful little technique called creating how might we statements. So these are kind of, I describe these as little mini briefs. So we have to kind of look at our system and identify what are all the little mini projects we could set up. how might we take an action for somebody to deliver a desired outcome, and what is the portfolio of projects, and how are we going to then kind of run that as a kind of a portfolio of transformation across our system. And this is where there's some really interesting models of transformation about. One of the ones I talk about a lot is a collective impact model, which is something that comes out of Stanford University, but it's about how you run a portfolio of projects where you're not really in control of all the projects, but by putting in place the right backbone organization, which has certain characteristics, a small team you need to support that portfolio. They have to be visionary, results orientated. They have to work like crazy to facilitate collaboration across the silos. They have to celebrate success. They have to be charismatic, optimistic, and energetic. So you need people with certain characteristics to drive things forward. They have to be incredibly politically adept, because you're always dealing with huge politics if you're driving systemic change. And they have to be humble. They have to let the projects have the limelight, not the backbone organization. So there's some really interesting dynamics about how you deliver system shift. Okay, so that's kind of just an introduction to patient ecosystem mapping. Hopefully you kind of understand what it is, roughly how you might create one of these maps and how you can use it. I've got a couple of little examples. So this is from Northern Ireland. This is South East and Health and Social Care Trust. This is their urgent unscheduled care. This is interesting. We've got thick arrows and thin ones. So we've painted on data. So these are big flows of patients, and it kind of just shows the flow of people into the emergency department at the Ulster Hospital. This is all the Ulster Hospital here. These are some of the smaller hospitals. And this was an incredibly useful map for kind of thinking about how all the different people across the system could kind of work together to rewire it. There was some incredibly interesting insights as to why the system was kind of broken and how you could rewire it. So that's urgent care in just south of Belfast. This was another one. This is social prescribing in Angus. So this was social prescribing is now deployed across Scotland. But nobody really knew what the social prescribing service actually looked like. And so we kind of created this representation using the methodology. And this was very useful in terms of making improvements to how the system was working. It kind of highlighted about 5 or 6 issues to do with social prescribing. One of the interesting ones, I think, was for me, what that came out of it was in the trends data. I can't remember the exact figure, but I think it was something like 80% of the social prescribing uptake was by female patients and service users. Only 20% of the uptake was male service users. And yet, if you look at issues, social issues such as addiction and so on, and their prevalence, they weren't really represented by that gender balance. So it was kind of very interesting about how the system wasn't necessarily creating equitable access. This was Scottish clinical genetics. This was another really interesting. I had the opportunity clinical genetics in Scotland is organised according to 4 regions, and with the clinical genetics teams, we created ecosystem maps for each one of the regions: the northern, the western, the eastern, and the southern. They all represent different groups of people, and we used the maps. The maps allowed us to kind of create an anatomy for a clinical genetics service. We created the basic anatomy, and then we were able to kind of map out how did that work across the 4 regions. So it's this is a bit like being in a veterinary surgery. If you're a vet, you don't know what's going to come through the door. You don't know whether it's a mouse or a cow or an elephant. But the way the vets manage that is they understand the anatomy of an animal. Every animal has a kidney, every animal has a backbone, every animal has legs. They're just in different places. So the vet manages to cope with these things at different scale. This is clinical genetics. The eastern one is a mouse, the western one is an elephant, and the other 2 are probably 2 other metaphors. But we could kind of work out what's the variance across those 4 services, which is incredibly helpful for the teams to understand what they could learn from each other. So that was done using the maps as well. This is a really interesting one. This is domiciliary care. This is care at home. This was fascinating because nobody understands how care at home works. So this was done really for the benefit of everybody who works in secondary care who is trying to discharge into this system. And it was kind of very useful for the people who look after domiciliary care to explain how it worked and what improvements could be made to it. And this is just kind of example of how we've taken that kind of baseline map, used it as a way of mapping all of the challenges across this system. And this is I think there's something like 15 improvements you could make into the system. So this is kind of where you get that idea of system shift. So we go beyond just kind of thinking about one individual project to thinking about the project portfolio using the approach. Okay, so there's kind of little bits of information I've got about it. I'll take some questions in a moment. So there's a kind of little overview that I've provided as a PDF, gives a kind of summary of how patient ecosystem mapping works. And I've recently written a paper about it for the Design Management Conference, which was at TU Delft in the Netherlands about 2 weeks ago, actually. So I've kind of written up quite a lot of the information that I've given out in this presentation and put it into this paper, which I've got a PDF copy of at the moment. So that's and that I've also kind of translated this into a kind of series of templates now. So I kind of have I teach this into the SQSF program, which is this run by NES, and into one or two other programs now. So I've kind of bundled the methodology up into a kind of half-day workshop where you kind of define your map your ecosystem, and then go through what are the challenges and drivers in your system and what's the system shift. So we're using these as kind of templates, either in Miro or printed out A1. You can kind of go through the methodology for a particular system. So it kind of operationalizes the idea with a group of people. Okay, so that's a little bit about me. So I'm a design and systems facilitator and educator working with health and care professionals. So kind of always kind of innovating with the methodology, but I do that with all sorts of really interesting people who work within the system, particularly in Scotland. With my other hat on, with my research hat on, in Strathclyde University, really interestingly, I work in a department which is design management, design, manufacturing, engineering management, but there's a lot of kind of systems engineers in the department I'm working with. And they're really interested in how do you model system flows. And I think this is extremely interesting. This healthcare has a lot of data, but it has a huge amount of data around what goes in and out of a hospital, but very little data around what I call the floodplain around a hospital. So how can you actually kind of begin to model that and kind of create systems models is extremely interesting. So there's a big research project that, well, it's a big research project. It's a pilot project with NHS Highlands and NHS Lanarkshire called Seismic Shift, which I'm involved with. That's looking at that at the moment with very clever systems engineers. And there's the Design Hopes project, which is another one with different institutions in Scotland, which is looking at green issues and sustainability in healthcare. And there's some really interesting projects. One with Abertay University at the moment, which is looking at gamification. So how can you create kind of systems models and use them to kind of model scenarios and build climate resilience? And another one which is run through the University of Dundee, which is how can you kind of use this approach to look at local level improvements from a kind of sustainability issue? So local level action on an individual ward, but how do you kind of join that together in a kind of systems approach? Okay, so that's kind of some of the kind of more speculative projects that are going ahead using the methodology. Okay, so that's my slide deck. My slide deck will be available to you. So I've sent it through as a PDF. So, and again, in my slide deck, if you want to get in contact with me, that's my email, tom@cofink.co.uk. I only use one form of social media, and that's LinkedIn. So if you want to connect with me on LinkedIn, please do so. And I kind of quite often post out about this sort of thing on LinkedIn. So you can kind of keep tabs on LinkedIn with some of the things that I'm doing, usually in very close collaboration and partnership with very clever people in health and care who share the interests. Okay, so that's presentation for me. I think there's a few moments available for some chat. So I'll just come off sharing now.